All right, so probably the only person that can out data geek me is Erin. But I wanted to focus on the health workforce for an aging population, which is an international issue. U.S. population projections, everybody has seen charts that look kind of like this. The little pink bar up there is the population expected to be 85 and older, and the green is the 65 to 84. And then you can continue down the population. We really are going to have disproportionate growth in the United States of that population of the 85 plus. Those are the ages where we often see increasing complexity, increasing serious illness. And just to make you more depressed, Alzheimer's disease is a growing concern. And these are estimates over time about the risk of cognitive and functional loss. And the numbers of people in different age brackets that are going to be experiencing Alzheimer's and other related dementias. So that purple bar in this chart is the ages 85 plus. So hopefully I've convinced you that we have an aging population that's going to have increasing complexity, increasing serious illness needs, including dementia and Alzheimer's care needs. Okay, so who's taking care of them? Well, that's an issue. The estimates are that by 2030, there'll be more than 70 million people in this age group. We're going to have the number needing long-term care by 2050 is going to more than double. And the National Academy of Medicine report from a decade ago, it is now the decade anniversary of the Workforce for an Aging Population study. And that projected that we need 3.5 million additional workers in order to meet the care needs by 2030. So these are substantial numbers of people. So what are the settings where this happens? For long-term care, 25% of it happens in institutions, nursing homes, assisted living, et cetera. 75% of the care for aging populations is in home and community-based services. It is not in institutions. So who's doing that? Within institutions, like a nursing home, if you go to visit a nursing home, you will mostly find a lot of certified nursing assistants or CNAs. You'll find some licensed practical nurses, and you'll find a few RNs. But it's mostly CNAs and some LPNs. The LPNs are usually doing the medication administration, and then the registered nurses are doing the overall supervision, assessment, care planning. That's your typical mode. What about home and community-based services? Well, this is kind of the cousin of Erin's slide of many, many, many people, and this is only touching on it. And I put these roughly in order of size of the workforce, although as you get down towards the bottom, it's kind of not really in that order. For home and community-based services, family, friends, clergy, community members are the number one caregivers for people with long-term care needs in the community. Number two is direct care workers. I'll define them more in a moment. Number three would be your licensed practical nurses, your registered nurses. Then as you continue to move down, you get all the variants of carpenters, therapists, pharmacists. Physicians are in that mix too, but in terms of numbers in long-term care, even physicians are by no means the largest proportion of that workforce. So when we think about transforming long-term care so people are better able to remain in the community, which is where people say they want to be, we need to be not thinking strictly about physicians, but that is how we tend to view our workforce. And we also need to be training these workforces in these home and community-based settings, which is 75% of the population. So what kinds of jobs are in long-term care? This illustrates my numeric point. The blue bars are nursing and residential care, and the green bars are home health services. So these are just two of the subsectors of the long-term care industry that you can identify through Bureau of Labor Statistics data. And I could spend a whole session talking about the data problems, and Erin would join me. But in these two settings, look at where the employment is. Nursing, psychiatric, and home health aides, which BLS lumps together because that's what they have data on. That's over 1 million jobs in nursing homes alone. Add to that nearly another 500,000 jobs in the home health sector. That does not include a job category called personal care aides. Personal care aides are in a different industry sector, and many of them are employed in the BLS industry data by households. They're privately employed. They don't even show up as being in the healthcare sector. But these are the people that you hire through an agency or hire directly yourself off a Craigslist to help get grandma to the bathroom and to go to do the grocery shopping for him or your grandparents or your family members who need assistance. These are the people who provide that daily custodial care, and they are unlicensed, and there's 1.7 million of them. So if you add those to the 1.4, 1.5 million nursing, psych, and home health aides, it's over 3 million people in those occupations in long-term care types of jobs, vastly outshadowing everybody else in the industry. So let's talk about physicians, though, because they really do have the highest level of education, a huge responsibility for coordination of the healthcare system. So for physicians, geriatrics is one of the key specialties for aging populations. It's a one-year fellowship. There are 152 programs with a whopping 343 trainees in 2017. A lot of slots are unfilled, and up to 80% of the slots, depending on the program and the year you look at, are filled by international graduates. In other words, people are not pursuing geriatrician careers. Why is that? Well, it's an extra year of training, and it turns out it's one of those specialties where you make less money after you do the specialization than you would have made before. So the expectations are a shortfall of up to 13,000 of these folks. A lot of them don't recertify. We don't even know if they're still working in geriatrics or they just didn't want to pay the fee to recertify and go through the process. So we don't have a great handle on this workforce, but we're pretty sure there aren't enough. Palliative medicine is another related field. That is a field, again, family or internal medicine typically, but also pediatrics, oncology, anesthesia. You can even find a few psychiatry fellowships in this area. 122 programs, 325 fellows, again, very small. And a shortfall of about 6,000 was estimated in 2010. There are only a few dual programs because, of course, people who are geriatricians never will encounter patients with palliative care needs. And palliative care physicians are never going to encounter people who are old. There's some cross-fellowship there, but not a lot. Honestly, there's a little bit of concern among the various groups that they kind of poach each other's potential candidates, which doesn't make sense, right? These are very hand-in-hand fields of specialization. And moreover, these are fields where, you might want to have 13,000 geriatricians. Is that even plausible? Probably not. So let's talk about nurse practitioners. As Erin mentioned, these are growing rapidly as a workforce. There are about 250,000-ish, and about 60% of them are family nurse practitioners. Fewer than 10% identify themselves as adult gerontological nurse practitioners. There used to be a separate gerontological nurse practitioner certification that ended in 2015. All programs now have transitioned to a combined adult gerontological. And the rationale behind that was if you're taking care of predominantly an adult population, most of your patients or a growing share of your population is going to be gerontological. So prepare in that from the beginning. It's kind of controversial. I don't want to get into that controversy. I'm not a nurse. I'm an economist, not my job. That's above my pay grade. But the education is an issue. The clinical preceptors are usually NPs. There might be palliative specialty programs that are joint with physicians and pharmacists and other providers, but most adult gero NP programs are very siloed. They are not necessarily training with anybody else other than nursing. So in long-term care, NPs are a growing share. These are Bureau of Labor Statistics projections. The top line is the NPs working in nursing and residential care facilities, and you can see the jump in growth expected between 2016 and 2026. That little dot out there is 2026. The next lower bar is physicians, and then the bottom bar is physician assistants. So the growth for long-term care, residential care is really coming out of the NP workforce. So I talked about home and personal care aides. What are their training requirements? And how do they fit in as a group? So this is a table we did for California just to try to educate people. And the project officer on this, she got the draft brief and said, I am so confused. And I said, yes, that is the issue. So California has multiple categories of what you would think of as people taking care of you in your home that don't have a license. Home health aides, registered home care aides who are affiliated with an agency, registered home care aides who are not affiliated with an agency, unregistered home care aides, and then we have this consumer-directed model called in-home support services providers. They all have different training requirements. Some have none. They're certified by different agencies or not certified at all. They have different scopes of practice depending on whether they're agency employed or directly employed or an IHSS or home health or what they do. It is confusing as all get out. So there's very little training requirement. That is one of the key takeaways. And the training is not with other health professions. So Here's my depiction of interprofessional training in geriatrics and gerontology. Top one is pretty much how much, say, geriatricians and adult gero NPs train together. They're sheep with different colored ears, but they are kept in different pens. Okay, the bottom one is how home health aides and personal care aides are trained. A personal care aide goes into your home and you train them individually. They are not trained in groups. They are not trained together. There is not a classroom for most of them. So they're little bunnies in their separate hutches. How should we do it? Right? In an institutional setting, you put them all in the barnyard and you teach them together. How to do it in home and community settings, you have them out there in the fields and you have them exposed to each other. These professions all need to be together. The home care aides need to be working with physicians and be able to communicate with physicians because often they may be the most articulate person with the most knowledge that the physician has to have. And if the client has Alzheimer's and dementia, the client may not be able to articulate their needs well. That personal care aide is the front line. But will the physician listen to them? Has a physician ever been taught who this person is and what they know? No, they're an unskilled care worker. They're not unskilled. If you watch what a home care aide does, they are a heck of a lot more skilled than most of us in this room. So how do we bring them into the care team? There are some glimmers of hope, and I'm getting my overtime now. Independence at Home is a demonstration project that came out of CMS. That program, the initial evaluation results basically say huge cost savings. These are home care-based teams, and these have a huge opportunity to expand. Veterans Health Administration is incredibly important. I have heard that up to 60% or more of our geriatric trained workforce across all professions has some rotation through the VA. The VA is a leader in patient-aligned care teams. They have nursing homes that have incredibly low turnover rates. It's really quite impressive compared to the rest of the field. And then there are some little pilot projects that have happened out there to train home care aides to be part of the care team. So there are some glimmers out there of interprofessional education programs that we can learn from that are in practice. And so hopefully that will get us going.
Thank you, Joanne.